Hey everybody, thanks for the invite. It's exciting to be here. This is, I guess, one of the nice things about going virtual is you get to connect with a lot more than what you normally did. I've been doing these all over the world now, and it's really cool. So, Chris, thanks for inviting me, and I think the topic today is going to be a pretty good one, and it'll keep our interest for a while. I'm going to go ahead and share my screen, not because I'm going to blast you with a lecture, but I think there's some background information that might give us a little context about this topic, which is actually pretty complicated and can be, especially the Maturo article got a little thick in some areas, and I think having a little background on this might be helpful. I'll give the ground rules of the journal club as we go forward, but let me just talk a little bit about medicalization and overdiagnosis. These are the two concepts I want to speak about first. So just a quick background, I've been a PT for 30 years, and I completed my PhD training at Texas Tech University in 2003. So guns up. And I also have a certificate in chronic pain management from McGill in Canada. Right now I'm a researcher at Duke University. I primarily do musculoskeletal research, do a lot of virtual type of research, telehealth, a number of other things. Have NIH grants, DoD grants, and a number of other areas. I do teach a few classes. I teach the research courses at Duke. And if you want to follow me on Twitter, which you should, it's at Chad Cook PT. So let me give you a little background on what got me interested in medicalization. I don't know if you all remember this, but there was a young man who unfortunately died after repeated concussions, and it was reported in ABC News in 2012, and they termed it second impact syndrome. And I'm willing to bet that the majority of you have heard this term before. And there was an actual ESPN article that talked about the fact that second impact syndrome is actually more common than the flu. They have since taken that article off because obviously that's sensationalization, but they claimed that it was something that happened all the time. It was interesting because when I talked to my neuroscience colleagues, their comment was, there's no such thing as second impact syndrome. So what we did is we actually looked at second impact syndrome as a legitimate diagnosis by using the World Health Organization criteria. And you may know this, the World Health Organization, these are the individuals who've created the diagnoses. In order for a diagnosis to be approved and to be placed as in an ICD-11 code or a DSM-5 code, it has to be approved by the World Health Organization. And they've built a structure on how to do that. And we looked at whether or not second impact syndrome actually met that structure, and it did not. So second impact syndrome is not a legitimate diagnosis. It is a term that has been created by a few people in medicine to perpetuate a medical approach. You could get overwhelmed with all the definitions, I think. Medicalization, overdiagnosis, social iatrogenesis, disease mongering, pathologizing, all of these terms are thrown out, and there's a lot of overlap. And one of my goals is that when we walk away today, we understand the difference between medicalization and overdiagnosis, since those are the two topics I'm going to focus on. Medicalization is one of significant interest, and this is the process where we take normal things that happen to us, whether it's socially, behaviorally, or biologically, and we claim it's a medical pathology. We pathologize it, and we feel like we need to treat it through medicine. You see this a lot now with mood disorders, where we're taking individuals who are shy or who are catastrophized about their current condition, and we medicalize that and turn it into something that's a pathology. The most common medicalized conditions is pregnancy. Low T, I'm at the age now where I get all these emails telling me, you know, be careful about your low T. It's all made up. Intermittent explosive disorder, which I've never even heard of, but it's basically anger, bouts of anger. It's angry people. And binge eating disorders, female sexual interest arousal disorder, overactive bladder disorder, premenstrual dysphoric disorder, pre-diabetes, pre-hypertensive, pre-obesity, osteopenia, pre-anything is medicalization. So these are all things that are fairly normal. These happen to us. You know, if you live long enough, you're going to get declining bone, but we have medicalized this into a pathology. These 8 conditions affect 180 million Americans. In other words, 77% of all adults in the United States meet this criteria of these medicalized conditions. So let's take a different look. Overdiagnosis is looking at something that is a legitimate condition, but because of overtreatment, you end up making the person actually worse than if you left them alone. So you take somebody with mild symptoms and then you pound them with treatment to the point where they actually get worse. So that's the term overdiagnosis. You see some people use the term overtreatment, but essentially overdiagnosis is overtreatment. And a great example of this is subacromial decompression, which is a surgery in the shoulder to increase the room or the space within the subacromial region. It has no better outcomes than any conservative approach. There have been 5 long-term studies that have supported this. There have been 0 studies that actually suggest that subacromial decompression does better than a conservative approach. So the most overdiagnosed conditions, according to the BMJ, is autism. These are legitimate problems, but they're overtreated. Depression, thyroid, prostate, and breast cancer. With respect to the screening processes, they do more harm in many cases with the screening processes. You'll probably notice that the criteria has changed a lot over the last several years. I'm at the age right where they flipped the recommended criteria for prostate screening, which is I'm happy about that. They are now pushing it up age-wise because you don't need to check people when they're 40. It does more harm than good. Low back pain, probably the most overdiagnosed condition that we've got. Headaches, and then syncope, which is essentially drop attacks. So I thought this might be useful because all of these terms are so overlapping. That our 2 terms we're interested in are medicalization and overdiagnosis. And the 2 are very different. This one has a disease process that's legitimate. This one we're making it up. And then all of these other terms tend to overlap in some way or another. Over-medicalization is a component of overdiagnosis. Pathologizing is essentially medicalization. These all fall within the realm of disease mongering, which falls in the realm of social and cultural iatrogenesis. And that's what our Italian article actually talked about. It really is sociological iatrogenesis, which I thought was quite interesting. In other words, manufacturing medicine so that it plays a larger role in society. It plays a dominant and a leadership role, and it changes the way the culture thinks about who owns their own health. And that's, I think, is a remarkable thing to discuss, and I hope we can get some good conversation going in our journal club. So let's look, who's guilty? Well, there are a lot of people guilty. You read that hopefully in the articles, but let's talk a little bit about some of the medical branches. We'll start first with allopathic medicine, which are our MD colleagues. And let's look at some low-hanging fruit of where they've really created some problems. Certainly the subacromial impingement syndrome, the push to make pain the 5th vital sign. And if you've ever read the story about how pain was pushed and it's led to the opioid epidemic, it's remarkable reading. And it was really pushed partially by the American Pain Society, which, by the way, no longer exists because they were found to be complicit in the opioid crisis, and they disbanded. So this is how big it had. A monstrous society like the American Pain Society has dissolved. Imaging abnormalities, if you look hard enough in an MRI, you'll find anything. And you can apply that because it's so sophisticated and technological, the patients are obviously going to believe it. Femoral acetabular impingement syndrome. Hopefully your faculty have talked about this. The proliferation of this disorder which somehow has only occurred within the last 10 or 15 years. There must be some sort of genetic anomaly that has taken over everybody because it didn't exist before 15 years ago. And now the surgery has increased by 8,000% in the last decade. So this is a very much too much medicine with respect to femoral acetabular impingement. Biceps tendinopathy, and then this is basically releasing the retinaculum during the surgery, has no evidence to support it whatsoever, but we're seeing more and more of these surgeries being done. And then spinal fusion. Fusion is appropriate for some populations, but we reached a zenith of over 450,000 fusion surgeries performed in the United States previously, and it's just flatlined instead of going up. Traditional osteopathic medicine is also guilty. Sacroiliac joint dysfunctions, all of these concepts of sacral torsions or in flares, out flares, up slips, down slips, these are all philosophical terms that were created by the osteopathic profession to justify a single person's vision on how to treat the pelvis. And none of these have ever been verified by any movement assessment. It is still used by the majority of clinicians, including physical therapists. Cranial sacral therapy, not even going to say anything. Homeopathy is something that was driven and created by osteopaths. And homeopathy right now is really taking a beating in the literature because it doesn't really seem to have any support whatsoever. Childbirth medicalization is very strong among the traditional osteopathic medicine. And then the medicalization of somatization. And somatization is just non-specific spinal pain in which you label this with ERS or FRS or whatever spinal anomaly that the clinician identifies, and then they treat that spinal anomaly. Chiropractic subluxation is the term used by chiropractors. Certainly you may have seen these kiosks where they do the free health check, and it's pretty amazing. They always find something wrong with your spine. And that is a heavy medicalization. Postural alignment and health, there's a very weak relationship associated with that, as we talk about in our paper. Preventative adjustments, no such thing. Manipulation of babies, terrible idea. T4 syndrome hasn't been justified. And then I've actually seen traditional straight chiropractors talk about energy disruptions. And I've had people talk to me about this before when I've taught courses, that they said, you have an energy disruption, and I don't even know what that means. But we're guilty too. As a profession, we have long since been very tied to this idea of postural anomalies and to treat these postural related problems. Scapular dyskinesia is a medicalization. It's a basically applying some sort of disorder associated with the scapula, even though you'll find as many scapular dyskinesia movement-related findings in individuals who don't have shoulder pain. SIJ dysfunction, as a profession, we've adopted a lot of the osteopathic concepts. Adverse neurodynamics, elevated first rib, piriformis syndrome, and now the big train is on moods and cognitions. So any of the pain neuroscience elements where we're trying to basically push the whole idea that the person's problem is related to their moods or cognitions, and there just isn't the data to support that. In fact, right now the fastest growing medicalized area is on mood. So I'd like to talk a little bit about the ground rules in our journal club, if you don't mind. The best journal clubs are those that actually have a lot of participation. And what I'll ask for is both comments in the chat room, whether you have a comment or a question. We love division. If you disagree with something, I think you ought to step up and say, you know, I really don't believe this. I think this is this. We'll start first with the Lewis et al. Paper, The Elephant in the Room, Too Much Medicine and Musculoskeletal Practice. And then we'll go to the other article, which is a little deeper, a little bit chewier, but it also has a lot of community-based elements built into it. So I'm going to stop sharing my screen. All right. And then I'll first ask, do we have any questions from the group? Anything I can clarify with respect to that brief introduction?
All right, I'll go. Dr. Cook, thanks so much for being here. Love your background. This is great. So my first question, actually, I'll just use one. You were talking about like with the medicalization of PT, and some of those technically aren't even diagnosable as like an actual condition. What are your thoughts about the use of like PT diagnosis and like the inability of being able to actually use medical diagnosis for physical therapy? And how would you recommend we approach that?
So the first thing I would do is respect the medical diagnosis, because that's the common language that we use, and it's also the World Health Organization's language. It's the language of research, and it's essentially the language of all professions. Within our Practice Act, we created these physical therapist diagnoses that are really built around impairments and other elements, and that's fine, I think, within our group to communicate if that's useful to clinicians, but to try to communicate that outside the profession, I think is a little bit of a challenge. They really don't know what it means. If it means something to you, you can communicate with colleagues. If it allows you to be a better clinician, then we'll continue to use it. I will say that it's fallen out of favor quite a bit. This was much more hot about 15, 20 years ago, and it's, I would say, at best lukewarm right now, the physical therapist diagnosis. Anything else to clarify? Awesome. Let's talk about the elephant in the room. This is our paper that we wrote. It took us almost 2 years to write it because the 4 authors could not have been any more different. We all wanted our own stuff in there, and there was a battle to include things and pull out. And this thing had at least 12 iterations. The paper itself points out a few things, and I'm going to just touch on these and I'll get your opinion. We talk about musculoskeletal medicalization, and it gives a couple of examples. Sham surgery is one of them, and that's really on the medicine side of it, that the amount of surgeries that are performed essentially off abnormalities in imaging and our concern related to that. And then the promotion of more expensive, more technically sophisticated techniques over simple techniques as being better. And we call those both, we had concerns about those. What are your thoughts on those from what you know?
I'll go. It seems like there's this drive across the spectrum towards making things theatrical, I guess would be the word I would use, because you even see within the physical therapy profession itself, it's not about, can we just get you moving? Can we get you more active? Can we possibly do something to help with your current mood state? And that's not even to say medicalize, but even just normalize. It's, we have to attach these like 3-letter acronyms to some new diagnosis as a means to church it up, instead of just appreciating the simplicity of a lot of this. And, you know, if you look across the board, I think as physical therapists, and this certainly is just the worldview that I see through social media interaction and even the journal club side of things, and we like to tout the papers showing that surgery sucks or some imaging modality doesn't have a good reliability or validity, but then we'll turn around and defend a paper with equal efficacy for even things that we really hold dear, like exercise, because it's in our camp instead.
That's exactly right, by the way. You know, the best conservative intervention, effect size wise, they're all about the same. There's no silver bullet. And that's, you know, that's the dirty secret nobody wants to talk about, but that's exactly right. With respect to surgery, I think one of the challenges is there is the aspect of harms, and the other challenge is the aspect of costs. So I think those two elements sometimes should push conservative care to be the favored intervention. And especially with a lot of the sham surgeries now, that they're showing that even if you just go in and puncture and don't actually do anything on the inside, there doesn't seem to be a difference compared to when you actually do something with the surgery. And that reflects value-based care. And has anybody heard of value-based care before? Have you discussed that? Kind of the best care for the money. Yeah. Thank you, Derek. That's good insight. Who else?
Do you think that with the new Stephen George paper that just came out, the PT and opioid use for MSK pain management, that it's finally, we're kind of talking about that low value conservative care as well? Before we were only calling out essentially surgery or the opioid epidemic, but it was finally time for us to start kind of calling each other out as well. Do you think that's a good way to go for us?
Yeah, so Stephen George is a colleague of mine, and here at Duke MSK, and he's actually done a number of things on the pain side that has talked about value-based care, along with Trevor Lenz, who's also here at Duke. And they've been, I think, at the forefront of that. I would say that they are agnostic when it comes to one's profession. They're both PTs, but they'll take a shot at anybody. And it was easy to take a shot at opioids, right? And here's what's amazing. There still is an escalation of opioid prescriptions. Even after the recognition that we've got an opioid epidemic, it's still escalating. So even though we've recognized it, nothing has changed with respect to that. And I mean, I've been part of, I think, 10 publications on opioids where we show this massive use of opioids after conditions or injuries that people shouldn't have opioids at all for. Like patellofemoral pain syndrome. People are getting opioids for that. I mean, that's just nonsense. I think it's going to take a while because I think the average person doesn't understand value-based care very well. And I also think that value-based care is a little bit more complicated than what people think. You know, we think it's cost per outcome, but it's actually more than that. If you look at the third arm of value-based care, it's patient experience, which leads me to, you know, how do you coordinate the patient experience? How do you change a person's perspective on what they think they need and what they demand? And as we know from the reading, patients are partly responsible for medicalization and overdiagnosis. So they've got skin in the game, as Shakespeare would say. I think it's going to be a while before we really start to see differences.
In regards to the over-medicalization of surgery, just thinking about patients I'm seeing recently who never tried conservative care before going to like a pretty drastic spinal surgery, or on the flip side, being in PT, doing great, and the surgeon being like, no, you still need a cervical disc replacement at 30 with no radicular symptoms. What do you think is the role of PT going forward when historically we don't have as much clout as, you know, for those of us who are just in private practice or in, you know, maybe a healthcare system? What is the role we have in fighting that? And is that even a role that we can play when we're often not respected as much in interdisciplinary settings?
Hey, Leon, that's a great question. And I'll give you a couple of examples of some PTs that are doing something that is actually really meaningful. One is Julie Fritz at Intermountain Health. And what she's done is she's gone straight to the provider. And she said, let's partner. Let's do some things. And you as the provider mandates what you'll pay for, because we're in a profession. All healthcare providers are in a profession where payment dictates everything. So, and you've seen a lot of third-party payers now say, no, we're not going to pay for any surgery unless they have 60 days of PT first or something of that nature. So Julie's one of them, going straight to the provider. Another one is Chuck Thigpen. And Chuck has worked with Blue Cross Blue Shield at different areas in South Carolina, in Illinois, and also went directly to the provider and said, let's build an ACO, an accountable care organization. Let's have a program in which we flip everything And we see those individuals first, and then we direct traffic on who should seek care. Now, the pioneer for this, trying to think of her name, she's in Australia now. I'll think of it in a minute. She likes gin. I know that because Linda Woodward, and she was in Canada. She's in Australia now, but she developed something called Spine Alberta, and this was a good 10 years ago. And then she worked with Canadian Health System that said anybody with any spine-related problems, they get filtered through a PT first, low-cost providers, and then those individuals will dictate whether someone has the severity level that would require a specialist to see them. The Canadian system said, hey, we love that because we don't like to pay for anything. And it reduced the amount of unnecessary surgeries. It allowed them to provide care to those people who really needed it. So I think that's what we need to do, Taylor, is we bypass our referral sources because, look, I mean, I'm a PT, I think like a PT. Chiropractors think like chiropractors. Physicians, surgeons, they think like surgeons. They're not going to think differently. It's just not in their nature, right? If your only tool is a hammer, everything looks like a nail. So that it's just going to be the way they follow. So bypass them, work with health policy, change policy.
Dr. Cook, with this paper, I know you said initially it took a long period because the four of you all had some pretty big differential opinions. Would you be able to talk about what was the hardest things for you all to agree on or disagree on?
You bet. Thanks for that question. So Peter O'Sullivan, if you follow him on Twitter or if you've ever had a chance to see him lecture, he has a number of lectures on YouTube, and he's a super charismatic guy. He's a really great guy, good guy. Does not like manual therapy. Likes to take shots at manual therapy. He does not believe it's useful. He's very much a hands-off and movement and exercise-related guy. And he's very much bought into a lot of the cognition and mood-related therapies that are being advocated across the world. And then there's me. Traditionally trained manual therapists. I know the literature on manual therapy. There is no evidence that manual therapy causes any type of a person being addicted to manual therapy or it leads to worse outcomes. That is all complete blog hatred and speculation. There's no literature to support that. So Peter wanted to include all the examples related to manual therapy, and I wanted to include all the examples related to the number one reason for medicalization, which is mood. We are medicalizing mood. We have created an ICD, or excuse me, it's a DSM-5 category for shyness. Shyness is now a disease. Did you know that? I went through my whole childhood with the disease of shyness, and I didn't even know it was a disease. I wish I had those days back, and I could have been medicated to fix it. So, but this is where we're at. I mean, we're making things up, but PTs are jumping on that bandwagon. Cognitive behavioral therapy. Do you know its overall effect in comparison to exercise, manual therapy, or any other treatment? Do you think it's better? Evidence has not shown it's any better. They all have the same outcomes. So again, it was a silver bullet that came around about 5 to 10 years ago. Everybody jumped on board. And now we're seeing that it really doesn't make, it doesn't make as big a difference as what people think. So those were the two biggest conflicts. Tammy Hoffman's background is really interesting. She's a big advocate of shared decision making. So if you're interested in that, and by the way, the evidence on shared decision making is mixed. There's actually a negative trial that showed that if you use shared decision making with the patient, it's Martin Underwood's paper on low back pain. But if you use shared decision making with the patient, your outcomes will actually be worse than if you tell them what they need. Isn't research fun?
Do you think that in the value-based care model that we'd be using, part of that would be cost. And then when you look at things like Start Back that try to get at cost, that's kind of why we're maybe looking down at manual therapy, just because it kind of makes you need to do more with the patient instead of like in the Start Back. Essentially, if you get a low Start Back, the treatment is essentially nothing compared to a high Start Back.
I think so, exactly. I mean, if you think about those individuals you have what, low, moderate, and high risk. And the moderate and high risk, we actually apply some therapy. The low risk, you just kind of smack the person on the back and tell them you're going to be okay and reinforce that. And by the way, that's probably the right approach, because most of those individuals have a really good prognosis. And it's really important that we understand prognosis to be able to recognize that. And by the way, the Start Back works in some countries. It does not work in all countries. You probably have seen the data. It's mixed. It works in really westernized countries, and in some of the non-westernized countries, it doesn't seem to work very well. So it's important to really look that up before we adopt it wholeheartedly. But yes, I think part of it is that there's a little bit more cost associated with manual therapy. I think the big thing is there's a lot of misunderstandings about manual therapy, primarily because people think it leads to addictive therapies or a passive approach to someone's care or anything like that. And there is no evidence to support that. There is none. I will say this. If you think about value-based care and that third element being patient expectation, a lot of people expect a hands-on based approach. And you're starting to see a swinging back of the pendulum to, hey, let's put our hands on people, let's actually work with some people, and then maybe the patient will actually appreciate that a little bit more. And I don't think that's a bad idea.
Dr. Cook, I certainly fall in the other camp of the anti-manual therapy. I think me and Dr. Sullivan will get along well from that viewpoint. And it's not necessarily that the normal self-efficacy debates come out of it. It is that over-medicalization of the therapeutic approach itself. And it's not that my problem is typically with the utilization of manual therapy so much as the narrative of you have adhesions, you have a trigger point, you have an upslip, downslip, whatever biomechanical pathology we want to assign to it. And I think personally, that's where my caution comes from, is the exact over-medicalization that goes with pathologizing things that either do not exist and have no evidence for their existence or are likely normal findings.
100% agree. I think all of that nonsense that was created to support philosophies that is still just carrying forward, whatever somebody's philosophical approach is and the dogma associated with that, I think that is extremely harmful for a manual therapy approach. When I think of manual therapy, I think of it as a pain modulator. And I think there are a lot of different ways to pain modulate, whether you want to use manual therapy, you want to use TENS, you want to use exercise. And there are many different methods. It doesn't have to be manual therapy. I think some of the challenges is when you have patients coming in who expect a manual therapy approach and you block them and tell them, no, I don't believe in that. I think that could potentially lead to either that patient deciding to pursue care elsewhere, or since expectations drive outcomes so much that it could influence the outcomes.
With that, as far as expectations, do you feel like what has been a successful way, or maybe not a successful way, that you've had that conversation with patients who do come in expecting it, knowing that it might be part of or they're a piece of the puzzle, potentially the ones that have skin in the game in driving some of these procedures? Because you hear about it on the medical side as well, like people demanding some sort of imaging or medicine or whatever to quote unquote feel better, or have a diagnosis for their own quote unquote sanity. So I think that from our end, sometimes that conversation is hard to make it not seem as though you are disvalidating them, but also explaining how, interventions A, B, C, and D will likely not be as effective, and or diagnosis A, B, C, or D likely won't change plan of care. So sometimes I struggle with how to verbalize that with people without them feeling like I'm being dismissive.
I look, and you don't look like a Zachary to me, but I'll call you Zachary. That's what your screen says. Look, that's the question of the day, and it's questions I've asked my primary care colleagues, my surgeon colleagues. How do you tell people no when they demand opioids and you know it's going to be detrimental for them, and they don't have an answer? And I don't really have a really great way to navigate that. I will say this. If you look at the evidence, no treatment is superior over another. So if that is the case, and you know the patient's probably going to have a pretty reasonably good prognosis, then it isn't really going to matter what you give them. It's just you're going to be a catalyst to their recovery at best, or you can throw gas on their recovery process by arguing with that patient as they demand an ultrasound or something that we know is relatively benign. So on my end of it, it's more about building therapeutic alliance with the patient and meeting their expectations, but also being extremely positive about, hey, you're going to do great. And just give them this picture of what you really need to continue to succeed. I think you need this, which might be an active exercise approach or an active-based program. Or sure, we can try that for a little bit, but we'll use that as a segue to X. And just have that communication and have that agreement with that patient. So we're in an expectations trial right now. We got an orthosection grant for it about 3 years ago, and we've been collecting data. We've collected data for about, 2.5 years. We've had about 50 subjects go through, and we've randomized them into a group where we're trying to change the expectations of the patient because they have these expectations. We're looking for people who have low expectations for PT and high expectations that they need surgery because their surgeons have told them that they've got this stuff in their shoulder that's all out of whack. And they think the only thing that's going to fix it is surgical repair. And I got to be honest, we don't have the data completely teased out yet, but I am the provider for the expectation side. And I don't know if we're going to change expectations. All I'm getting is pushback. And this is a 6-week cognitive restructuring program that was developed by Frank Keefe, who is the editor of Pain, Stephen George, and me. I mean, it is a very sophisticated, I don't think we're going to be successful. It is, I can tell pretty much on that first visit, somebody just blocks me out, they're not going anywhere with it. And so I think you're running into some fruitless discussions if you do that. That's my take as a clinician.
So with expectations, since they're so hard to change, wouldn't we want to get there earlier before that expectation has been made? Kind of looking at Mary O'Keefe's work on this and like getting to the community and putting out good information out there. Like, what do you think our role as clinicians are for this stuff to try to get there before that expectation has been, because it has to come from somewhere, right? You're not just born with this expectation that surgery works.
Yeah, John, well, that's a perfect segue to the next paper, which was very much the sociological medicalization and how society and their whole processes, the way they think, has been completely altered, and that people have essentially divested their own responsibility for their healthcare and they've given it to the medical profession. They've given it to big pharmacy, and they think that that's where I will receive help. So what is our responsibility? We are a small fish in a big pond, and we have to do, first of all, we have to do sophisticated research so that we can support that what we do is actually meaningful. And then secondly, we have to find an avenue to be able to report that. So Mary has elected to use social media as her platform, and she's done a nice job with that. Others have, and Mary's postdoc advisor is Chris Marr, and he is elected to provide really conflicting information. He will argue that seeing a PT first or seeing a PT for every MSK malady is a bad idea, that it will lead to overdiagnosis, overtreatment, because PTs don't manage that well. So I think we're getting mixed information. And by the way, Chris's voice is much stronger than Mary's voice, because Mary's relatively new, recently minted PhD, 2-year postdoc in Sydney. Chris Marr is the #1 low back pain researcher in the world, by far, with over 650 publications. He's on every board. So he's a PT, and he's saying this. So I think it's rallying together, saying a common voice, but recognizing that we're going to have to change society somewhat, and expectations within society.
Dr. Cook, with this paper over medicalizing normality, do we have any clear working definitions of like normal versus abnormal, or normal versus pathological?
I would say the closest you can get to that, and actually having a working definition of what pathology is the World Health Organization criteria, and in which they actually outline 4 different features that a pathology or a disease has to fit all 4 of those procedures, or all 4 of those criteria. And for example, second impact syndrome, it fit 2 of 4, and it's not unique. The reason it took so long to diagnose Ebola is because initially it did not have unique criteria. It looked like other things. So it took a while for them to actually recognize it as a unique disease. So I think the World Health Organization criteria is probably the best place to start. And the majority of the countries of the world use it, and the majority of the professions of the world also use it too. France doesn't use it. It's interesting. What's really interesting is the very first diagnostic codes were created by French physicians. And at some point along the way, they dumped the concept of a common coded system. Do you feel, as a group, that society has been medicalized? And if so, what are some examples that you can throw out that you think that are normal things that happen to us that are now being medicalized?
Yes, posture for one, easy one. I mean, if you look on social media, every 2 seconds, it's like, fix this or else.
So you look like a Zachary, and I agree completely. Posture is a big one. What else?
Movement. I would go even broader into movement. We've now decided everyone in the way they move, there's some pathology associated with how many degrees of freedom your knee has, if you have enough ankle dorsiflexion, if the wind is blowing from the northeast and you happen to step on your left big toe.
Derek,
This whole movement systems.
You would get along really well with Corey Simon, one of my colleagues, who does not feel that everybody benefits from movement. Or Dan.
So
go ahead.
Full disclosure, I was trained by Steve, and Trevor graduated a year ahead of me. So
yeah, Corey.
The whole movement systems expert stuff is just a joke.
It's movement evoked pain. You know, Corey's into that. And Dan Pinto gave me the best example, because Dan Pinto, he's up at Marquette, and he does a lot of decision-making related research. And he was telling me, he goes, what do you feel about this movement push? I said, you know, I know we have to have a shtick or a banner. And I guess, you know, the selected people have bought into that. But Dan's example was this. He said, he goes, take homeless people, because they don't need more movement. They need stability. They need, you know, they don't need to move from here to here to here. They're moving all the time. And, you know, you have to take that with a grain of salt. So what else? What else is medicalized?
Dr. Cook.
Use MRIs.
Overuse of MRIs? Yep. I see somebody in the chat room said the overuse of fibromyalgia is a diagnosis. I mean, that's what you get when you have a syndrome-based diagnosis. And then, do you know what the Canadians did with the diagnosis of fibromyalgia? They eliminated the 18 tender points. They said, oh, you don't need any of that. It's just widespread pain and something that's lasted for 6 months or more, and we'll call that fibromyalgia. It's like, well, heck, that's almost everybody. That is too sensitive of a strata for clearing poor diagnosis, I think.
Something that's mentioned in the risk and health section of this paper related to mood and cognition, talking about how it's much easier to diagnose a child as having a chemical imbalance rather than addressing like the social determinants that may have led to a mood, them to act out. I think that was pretty interesting and something that's also overdiagnosed in our society.
100% agree. And I'm so glad you pointed that out. I actually highlighted that section of the paper, because especially now that we're in our political climate and we've got to sit through this nonsense that we're listening to right now from both sides, and recognizing that if you really want to know what drives health, it's social status. It's whether or not people have access to the things that they need. It's proper foods. And none of the, being on the backside, waiting for people to get sick is going to fix that. There's my PhD student, or one of my PhD students is Zachary Thorne. And Zach's big thing is social determinants of health. And my gut tells me that you being an educational program in Texas, you're getting a lot of that because you have such a wide social strata within the state of Texas, and such a huge influence of culture on a person's health status. And those are elements associated with social determinants of health. And we've published 2 papers and have 4 coming out that show that the social components associated with recovery for OA and surgery are as strong as the biological components that the patient actually has. So the social piece is huge, and that was recognized by the second paper as well.
So in that token, how do you say we combat and I don't know if combat's the right word, the rise of social media siloing into these diagnoses? Because now we have like osteoarthritis support groups, low back support groups, and if we're being honest, the support that's being offered there rarely is remotely in line with any type of evidence-based guideline.
You're right. It's an echo chamber. And what is it? Who's Karen from Facebook now is the expert, but that provides all this information for individuals on social media. I think it's very difficult to combat that. I'm actually giving a journal club for our own Duke students on how do you navigate social media? What are the pros and cons of social media? And actually, I have a paper that we published, I think in 2018 in JOSPT, where I took some of the major leaders in MSK, including Steve, he was on it, and we talked about the pros and cons of using social media as our mechanism for information, or to pull information from research. I think one of the biggest problems with social media, outside of really influential people spouting nonsense, is something called source amnesia. Have you all heard of the concept of source amnesia? Well, I'll give you an example. Source amnesia is where you hear something, and let's say you're on Fox, and you're watching Fox and Friends News, and you hear that some Democrat is trying to have all firstborn males exterminated. And you're like, what? This is total nonsense. 2 months from now, somebody brings something up about firstborn males. And you're like, I've heard that before. Actually, I've heard that. And source amnesia will often elevate the credibility just because you've heard that previously. It really goes out. It goes off the rails if you hear it repetitively. And that's what happened with manual therapy. How many times have you been told that manual therapy leads to addiction behavior, where the person becomes addicted to the manual therapy? There's not a single study that has ever supported that. But I hear it every time I talk. I see it on social media, I read it on blogs, and it's just people saying it over and over. And They forget where they heard it. I heard that from Adam Meekins. He's completely not credible, but you forget it was from him, and you think it came from New England Journal of Medicine. So I think that's a big problem with social media. So I don't know how to combat that. I just think that we, as clinicians, need to be very balanced in where we get our information, and make sure that you fact check things.
I've asked that question before too about the like looking for the evidence to support or not support the whole manual therapy leads to more manual therapy or whatever. From my understanding, there's just a lack of evidence. It's not that it goes one way or another. So therefore, we couldn't say, like, we can't say one way or the other. Correct? There's not a study showing the opposite either.
Geronimo, there's not a causation-based study, so that would be a trial. And there's not an associational-based study, and that would be just either by happenstance or that possibly there's a pattern there. It's never been studied. It is affectionately called a wives' tale. Now, it may be studied and it may actually show that, but I do know the literature pretty well on manual therapy. What I do know is this: people who have low self-efficacy and a more passive approach to their own healthcare will seek passive providers. That doesn't mean the passive intervention, manual therapy, TENS, whatever, it doesn't mean that that's a faulty intervention. It just means that the people that are seeking that are a certain way. I mean, if you think that with a few manipulations you can affect somebody's self-efficacy, then you're pretty magical. That is not an easy thing to change. All right, and that's not easy to change with cognitive behavioral therapy. It's not easy to change with exercise. Self-efficacy is pretty rooted, and it's probably not going to change with a few interventions. One last thing, and I'm not going to quit, but in relation to this, with respect to passive intervention, we've poo-pooed on those for 10 years now. A recent study actually is a value-based care study where they looked at the best outcomes, best patient satisfaction for the lowest costs. And it was for OA of the knee. And the winner was TENS. We stopped teaching TENS about 5 years ago. And then when Corey Simon came on, he said, you got to teach that again because it's actually pretty good. And I mean, I don't know what to say.
To follow up on that comment about TENS, do you think that suggests that sometimes value-based care doesn't mean physical therapy? Because anybody can go buy a TENS unit off of Amazon and there's nothing really skilled about it, just like there's nothing really skilled about rubbing a hamstring 5 different ways. But maybe the problem then is we think that we want to be the provider of choice because, hashtag get PT first, when really maybe we're just an entry point to self-management of, hey, you have knee-OA, here are a couple things you can do to stay active, and this little machine that you can get on Amazon for $20 is, proven in the research to be really helpful for people like you. Here you go, have at it, get on your way, instead of putting ourselves up on some pedestal of like PT solves everything.
Taylor, you're a heretic. How did you get into this program? No. Actually, let me just tell you something. I'm meeting next week with a group called Kaya Health. And Kaya Health is an app-based program that provides musculoskeletal interventions over an app through AI. And it gives triggers, so the patient actually gives feedback on how they're doing. And there are triggers which actually punts that person to a live person who steps in. But in the majority of the cases, if nobody hits the triggers, they continue to cruise along using the AI and they do fine. So I don't mean to be, I hope this doesn't come out the wrong way, but if we're really looking to change the healthcare system, and that's what we ought to be doing, not protectionism for our own profession, but to actually go in and say, what is, if we could redesign this from the ground up, what would it look like? There would be an element of blocking care choice. There's no question about it. That you would have to go through a threshold and then see a low cost provider first, who's not invasive, who can filter that person's continuing movement through the system. It's the opposite now. I'm guessing Derek's probably one of your teachers, right? He probably told you, we have a flipped system. It is a system that basically you see the specialist first. That is not the right way to go. So if the right way is a really well done app with AI and triggers, then I say go for it.
Well, it seems like that also opens up the opportunity for us to actually practice at a doctoral level instead of watching somebody do 2 sets of 15 clamshells for a sprained ankle.
Yep.
So I'll ask the real fun, hard question out of this method then. Do you think we've saturated the market with having 220 PT schools?
Yes. How about you?
Absolutely.
Yeah, I actually think it's getting worse. I was just on the CAPD website. We're booked out until 2015 for site reviews for new programs. And that really concerns me. And I'm guessing the UT San Antonio system is affiliated with the healthcare system. Is that right? Do you have a partner that's a healthcare entity, or is it independent?
I think we're with, I don't think we're independent.
Okay.
Yeah.
Look, my big concern are non-healthcare affiliated small private schools that are proliferating. The last 20 startups, out of the last 20 startups, 19 were small, private, non-healthcare affiliated programs. And I think the experience is different there. I don't think it trains the individual the right way. I don't think you have the breadth of knowledge of how to actually manage people within a system. And Derek, to answer the question, I do think so, yeah. I think we're gonna see a correction.
So besides working with, the insurance companies and that sort of thing, what do you see as practical steps that can be taken to provide more accountability in this space against overutilization specifically of PT services? So I'm thinking of, I'm a recent graduate of George Fox, so I practice in Portland, Oregon, and I have seen patients for my boss that I'm like, you're seeing them for 27 visits for what? Just very, very old school in that thinking. And the thing I just realize is, owners have gotten savvy and market to demographics whose insurance doesn't require authorization, or they're pretty open about how they massage their notes or their outcome measures to get more authorization. So it just seems like there's this kind of free-for-all where PTs do what they want regardless of what the evidence says. And maybe I'm just cynical here, but what do you see besides going to providers or to payers directly? Is there anything else that can be done to have more accountability?
I think, so I'll answer that 2 different ways. The first one is I think capitating care, where you put the responsibility on the provider to manage it a cost-efficient way, is a good way to go. And that requires a lot of negotiation up front and being able to go and capitate, go to a large provider or a large manufacturer and say, we'll cover every single one of your individuals. But it's not easy to do in today's market. It's not easy to do because basically these gigantic companies buy up all the insurance. There are 2 colors of blue in North Carolina. There's Duke and there is UNC, and they control the healthcare market in the whole state. And if you want to try to get in and pull some of that out, good luck, because they're so powerful. The other way, I think, I'm not a huge fan of using outcomes measures, pay for performance. And here's why. We make this assumption that a person's outcomes measure change is actually related to the care provided, when in reality, the outcomes measure is related to the person's health status. And what I mean by that is if you get a bunch of super sick people, if you have somebody you're treating with knee and hip and shoulder problems, and they also have COPD and 50 other chronic, preventable, lifestyle-oriented disorders, their outcomes are going to stink. And it's going to make you look like you're not a good clinician because your patient population is less healthy, and outcomes measures measure health status. They don't measure recovery. So I'm not a fan of pay for performance. And you know the black magic associated with MCIDs, right? And that there are 6 different commonly reported MCIDs of the oswestry. And those, and we looked at these in 2012. If you're building predictive models on an MCID, which is what insurance companies love, you will build a different predictive model for each of those different MCIDs. And so I'm just not a believer of pay for performance. So that didn't really answer your question, but I'm not sure I can answer the question.
So one question. You go, Derek.
Do Jim's question? No, I was going to read. Dr. Eubanks asked, can you briefly address the integrated health systems model regarding the implementation of high value care?
I'll try. For the military, or because that's the one I'm most familiar with, is integrated health.
Thanks. Great talk. So we first met back, I think, 2017 or 18. So Anand Joshi, I went to Brody, so I'm an MD-DC. And I'm at the University of Pittsburgh Medical System now. And so we're an integrated health system. And we have a very unique relationship between the PT program here, physical medicine and rehab, orthopedics, neurosurgery. There's a lot of alignment due to the nature of our health system, because we have unique pressures that are driven from the top to collaborate and work together in ways that are not present in many other models. So the integrated model does seem to be gaining ground because it's profitable, right? And it's a good competitive model now, whereas before that was sort of speculation. But UPMC, is a $22 billion system now, is sort of showing its viability. So what do you think the future holds in terms of changing some of these problems in different ways because of a pressure like an integrated health system that will drive change a little bit more systemically?
Well, I think, so I believe that a system change is going to lead to much better results than individual clinician changes or clinical practice guidelines or any of these 50 different things that have been thrown out there. So at a system level, I definitely would argue that that has to be done. And I can't really talk about PMC system because I know nothing about it. So I'm completely ignorant on that. I do know about the military's step care model, and we just evaluated that. And it seems to me that that's similar to an integrated system in which there are filters that a person goes through and targeted individuals that that basically they're pushed at toward first. And we just got a paper accepted on that too, and it does seem to reduce costs. And then the only area that we had outliers were the extremely sick individuals. They didn't seem to have any type of reduction, and we couldn't explain it. We just didn't have an explanation for that within our paper. But I would argue that you probably know more about it than I do, if you want to talk about integrated health.
Okay, thank you very much.
Mm-hmm.
Shelby had a question, but she had to leave. So on the chat, she asked, you mentioned ERS, FRS, SIJ, dysfunction, elevated first rib, et cetera. Since those are the things still being taught in school, residency, fellowship, et cetera, how do you think we go about changing that?
Yeah, I mean, there are a lot of things still taught in school that really haven't been shown to have any evidence in clinical practice. And there are a litany, and I don't know which orthopedic textbooks you use, but I mean, all you got to do is open the chapter on shoulder tests or SIJ tests or whatever. And then a majority of those really don't have any influence on post-test probability at all. So, but you still have to know them. And I think it takes a while. There's a kind of a tail whip effect to where we actually divorce ourselves from those concepts over time. And I think it's important too to at least know what they are, so that when you're out practicing and you communicate with your clinician colleagues, you're familiar with those. Not to debate them or to berate them for using it, but just to understand your own position on why you would or wouldn't use a particular technique.
I guess kind of building on that, and first, thank you for coming on today, and really appreciate your perspective and everything you do for the profession. But I'm really curious about some of your perspective in the academic world, about any blowback that you've gotten or received, or how the general attitude is. We're lucky we get to talk with and learn, and chat with so many different academic institutions and students, getting their different perspectives of going through programs. And unfortunately, there are still a really high volume of programs that are teaching a lot of this without the dash of humility, where they're kind of like being transparent about some of the shortcomings of it. Yeah. So, I'm curious, first, your perspective on your experience with different, academic institutions and you kind of advocating for this stuff, and B, if it is something reasonable to expect academic institutions to lead with a little bit more of the humility, because I agree it's good to learn these things and reason through them, but I worry about, the high percentage of cohorts going out who aren't, thinking critically about anything that they're learning. They're just taking it because that's what they're told. And then they're going out and, creating a lot of these societal narratives that we're sitting here talking about. How do we change society?
Yeah.
Sorry, that was a lot.
No, that was good. There are studies that show that the way a person continues in the profession is very heavily rooted in what they learned and during their formative training years. So it does matter what people are told, and it does matter the amount of zeal and emotion that goes behind a particular training approach. And if a person teaching cannot really be independent on how they present the material, then you're going to get a very biased approach in a particular area. So that is a challenge. I think trying to navigate that with in the United States, if you've seen one DPT program, you've seen one DPT program. They're just so dissimilar. But getting back to your very first part of your question, which was, have I ever received any blowback? Oh, heck yes. I get a lot of nasty stuff on Twitter. I get a lot of people that will openly argue with me about things, but it's an emotional argument, and I don't argue emotions. If somebody feels a certain way, that's perfectly fine. I have no problem with that. If people actually saw what my stance is, there are no superior interventions. We will continue to try to identify pathways to prioritize patients for a particular intervention, but we haven't sorted that out yet. We're probably going to make bigger changes if we change the system. And that system may mean that we are blocked in many cases from seeing patients that we shouldn't see. And I don't have a problem with that. So I'm as open toward other ideas that are better for the patient in the long run. And that's hard to argue. I've been seen as a manual therapy homer, but I am also one of the first people that lobbed grenades into many of these old, awful, dumb theories related to manual therapy. Like Fryet's laws. We were the first to publish that said, hey, this is a joke. This research was from 1905, where they cleaved the legs off a cadaver, stuck a person on a board, and somebody rocked the board back and forth and looked at the direction that the spine went. That's where Fryet's laws came from. And if you actually look at 3D radio stereogrammatic assessment, RSA, it doesn't follow the pattern at all. So I'm able to balance that, I think. So, and most people don't argue with me that much. The biggest problem area is Europe. Europe osteopaths, and osteopaths in Europe are not like medical physicians here. They are very much like advanced manual therapists. And they will argue, it's as if you kicked their grandmother. They will argue and argue their point And I'm just like, okay. No, still don't believe it.
Yeah, I mean, it's just, I think it's to that point too. And like Taylor, I've spoken with her. She's at George Fox, and it sounds like and also at Duke with I know the faculty there. It's still teaching to some of the stuff that you need to know for the boards, and honoring the tradition of it all. But you can still like be transparent and have some intellectual humility. And I guess from the outside looking in, that's one of the things that concerns me the most from a leadership perspective, is just seeing a more collective want to have that transparency and humility, so that we are able to actually move things forward as a collective and have more. One of the things you talk about in Elephant in the Room is consistency in some of the narratives, even interdisciplinary.
Agreed. And you're talking about that humility. There's a person named Klein, and I think it was 1995, they actually studied the level of confidence that a person had and the accuracy of their diagnosis. They're inversely proportional. So the best clinicians are the ones that are like, this is what I think, but I can easily change my mind as that data comes in. I'm not going to try to force fit something.
Question for you on how you're saying that maybe not seeing PTs at too early might be the way to go. Then where would PTs fit into this? If, let's say, like, we would see maybe manual therapy would be done by a manual therapist, and then the PTAs would essentially become what PTs are doing now. Wouldn't a PT then just become a non-residency trained primary care practitioner as an MD?
Yeah, I think, a lot of it, what they do would be like a non-residency, primary care physician. I do, and for musculoskeletal problems. And I don't like to go outside my boundaries on other health maladies. I'm not sure where we are with that. I know the MSK literature pretty well, and I know we can do that pretty well. But yeah, I think we would play a huge role that is currently performed by primary care physicians. But I don't think that's a bad thing. And here's why. If you look at the medical school education on musculoskeletal training, and do you all know how much they get? I'm guessing you
About
get
2 courses in a good day.
I'm guessing you all get at least 2 semesters, right? Of musculoskeletal, plus all these adjunctive courses that buffer that. Medical school individuals get 2 weeks on average of musculoskeletal training, 2 weeks. And then unless they receive that in residency or fellowship training, and most primary care physicians don't get that, they're not going to have the background that we do on musculoskeletal problems. Unless they specialize in there, they're sports medicine specialists or something of that nature, they're not going to have that background. So I'm okay if we're the ones that are actually the filter for that. I'm okay if we're pushed into a role that's a little bit different than what we typically do with administering exercises, hands-on, whatever. I think that's still part of who we are and what we can be.
Dr. Cook, do you want to move quickly to the other paper, since I know you're limited on time?
Yeah. So I only just want to get your perspective on, are we continuing to go down a path of sociological iatrogenesis, that we are making our population less healthy by what we feel and hold dear with respect to how we look at medicine as this savior? And then I'm going to take a step forward even further, especially with today's events with COVID and with our election and with the different ways that the parties actually push their principles onto the population. Do you think that we're continuing to see more hazardous problems with that, or do you think we're going to correct ourselves?
I mean, if history is any teacher, we're going to continue down this path. And right now, it seems like there's this movement to, everything is so data driven that we have gotten, I think we're falsely seeing a lot of signals and a ton of noise. And as soon as you start monetizing everything from like how many steps you're taking a day to, pick some metric, even in terms of like velocity-based training, everyone wanting a Tendo unit now. We're so hooked up on this. I'm forgetting the name of it now, and I'm wanting to call it Godwin's law, but that's the Hitler. That's not the whenever the outcome measure becomes the test. And we're just tracking all of these metrics. I mean, there's the Lutz paper that's like the history of low back pain that talks about like every time we got a new imaging modality, we just changed what our diagnostic problem was. And it seems like the more we're delving into this information age, the more we're just creating new problem after new problem after new problem.
Derek, do you think that decreases the responsibility on the patient and on society to be responsible for their own health?
Yes, I think it kind of gets back to some of the things you're starting to see with the discussion about, the monetization of social media even. And if a service is free, you're the product. And I think we're starting to see that with the information being given out, whether it be in good spirits or nefarious, it is about how do I draw this person into my door? And all we're doing is taking that onus away from the patient and putting it on us.
Yep. And I think that, the thing I liked about the paper and the reason I asked you to read it from the Italian author is because, first of all, it dug a little deeper than our viewpoint did. But secondly, it talked about the role of politics, the role of how you give something to someone who can never take it back, and just culturally, how things have changed so much. And I've had the luxury of being able to speak in multiple countries, and just to see the differences in the expectations of a person's own responsibility for their own health in selected countries versus ours, I got to tell you, it's huge. If you go to the Scandinavian countries, they have no interest in the medical care system. The best they could do is to never encounter those individuals whatsoever and to manage their own care. And the lifestyles make a huge difference, which is one of the reasons you see their scores really high in the comparative healthcare systems, because they have better product to work with.
But even there, that's an interesting conversation because, like, I'm from rural West Virginia. When we're talking about health disparity, like, you're in the epicenter right there. And to your example, there's a huge distrust in the medical system within those rural parts of West Virginia. But I would argue it's the other side of it, to where you're getting shit care. So they've just learned to not trust it.
Good point. Yeah, in the term power distance, I don't know if you've heard that before, but that is a lack of trust. And different cultures have different levels of power distance. Like right now, our African American population have a real power distance problem with individuals in authority, and that includes medicine. But no, you're right. And it's the VA too, right, Derek? We do a lot of research in the VA. And you know what the average musculoskeletal visit is in the VA? How many visits they get for all disorders, musculoskeletal? It's one. They get one visit, and then they're typically lost in the system. That's the average. So there's a lot of crap care out there.
Dr. Cook, the JOSPT Insights podcast you were on, I re-listened to it this morning, and there's a quote where you said, "We are in a society in which all pain is abnormal." And I think it kind of parallels what we're talking about, so I wanted to bring it up. But how do we like differentiate between a patient, like validating them on their pain and their experience, and also having the conversation that they shouldn't be kind of catastrophizing or being hypervigilant of these things that are maybe like societally ingrained?
Yeah, so I see two things there. And what I was talking about in the podcast was that as a society, we no longer accept that there is some pain with aging, that there is some pain associated with increased activity, that all pain is now abnormal. And part of that was the whole pain is the fifth vital sign nonsense and how that was pushed. And it was partly as big pharma, the APS, and a number of other groups that are really pushing that, hey, you got pain, you need to take care of that. So as a clinician, I think to navigate that, one of the first things you need to look at is how has the pain influenced the cognitions and mood of the patient? Has it gotten so far that you're starting to see behavioral changes in those individuals? And if you see those behavioral changes, that's where you start to see declining health. If you've got a person that has pain, but they're still active, it doesn't limit them, they don't have negative cognitions, I don't focus on that as much. But those people that have true legitimate behavioral changes, and you'll notice it because the patients will tell you, or their significant others will tell you, that they're not the same. They've changed their behaviors, they've changed their lifestyle. To me, that's pretty meaningful. The second thing I look at is I look at the pattern of the pain. And this is a concept called pain adaptive. And I hope you've heard this before, but it's basically a person has their own endogenous capacity to modulate their pain, and it's typically done through either movements or positions or whatever. So if you've ever seen the McKinsey program work, or if you've ever seen someone do manual therapy and it actually makes a big difference, or a person who exercises and it helps modulate their pain, a lot of patients with OA do that. It generally means they're pain adaptive and they respond really well to their own approaches or external approaches to modulate pain. If I see somebody like that, prognostically, it tends to be a really good outcome. We studied this in 2014. We found that those pain adaptive people tend to have really good prognoses for spine-related problems. And I tell them, I say, hey, this is a really good sign. This is really cool. Look what you can do on your own. And here are some exercises that will modulate on your own, and so that you can self-modulate and improve. And and the reason I do that is because if a person knows that they can manage their own pain and they can influence their own pain, they can modify it, it's actually a really powerful thing to them. It's very meaningful to that patient. So those
to circle back to your earlier point about the over-medicalization of beliefs about pain or cognitions around pain, but then to tie that to your recent statement about noticing those changes in a patient, do you recommend a particular tool to screen for that objectively, or is there an established threshold at which this is maladaptive, or no, it's not, or yes, I need to refer them to behavioral health, or no, I don't? Or is that still in the murky waters of who knows?
There's a tool, it's called the BAT back, and it's for the spine. And Derek may actually know it, or he may actually teach it. But when we evaluated this last year when we spoke at CSM, we looked at the 3 different tools that actually assess pain-related behaviors. And the BAT back was the one that, if you look at the Cosman criteria, it was the one that checked most of the boxes. There are 3. There's another one called the Keith Block test. And then there's a third one, which I don't remember the name, but the BAT back was the best one for behaviors. But I think a good patient history is going to give you some perspective on that. And because this is the thing about when you're dealing with moods and cognitions, you can influence moods and cognitions pretty quickly. You change somebody's pain pretty significantly, you see a massive drop in their negative cognitions and mood. If you increase their pain really significantly, you see it actually ramp up. They're very directly proportional. Behaviors, way more difficult to intervene on. Those are think of your fibromyalgia patients. Most of them have dug themselves into a behavioral hole, and to get them out of that and to change their behavior is a pretty lofty task. So I really look at that. Has it influenced their behavior? If I have somebody who says, I'm really concerned about this, I'm nervous that it's something that's going to last, but I see them just popping around doing fine and managing it, not that concerned. I don't put them on a 10-week CBT program where I overdiagnose a mood.
We don't really have a treatment anyways, right, for like persistent pain. So like, what would that change anyways?
Yeah, I think the lifestyle modification, if a person, I forgot what it's called, Frank's got it. It's a cognitive behavioral program that has something around acceptability. I can't think of it right now, but it's basically coming to terms with it in managing it. And Frank Keefe really advocates this.
It's acceptance commitment therapy, but even that doesn't really have that much data behind it.
No, it's different. It's different than acceptance commitment therapy. It's I can't think of the name, but Frank's coined it. And you probably know that the psychology profession's a lot like the PT profession. We have all these little philosophical fiefdoms, and none really are better than the other. If you look at that, it's called shared. But I can't think of it right now. But I think general lifestyle-oriented things, aerobics, resistance training, you're going to get some gains, especially on individuals that have had behavioral modification that has led to negative lifestyle choices. But I don't think there's a silver bullet. And I don't think you're going to see a really high percentage of successes if you look at the literature on that too. It's a tough gig as a PT. I'm all sunshine and rainbows, by the way.
Dr. Cook, I had a question. This sort of overlaps between this paper as well as the first one. And you've mentioned moving more towards like a value-based care system. And so there's a little bit of, there's one of the drivers obviously is the patient, the people that are coming in, what they expect. What would you recommend for, as far as a individual practitioner, how would you best support improving value-based care? And then furthermore, for like the policy makers on that side of things, do you feel like value-based care looks different in the sense that it is then like an order of operations and how the patient flows through the system does value-based care, I guess, mean different things from the individual healthcare provider as well as the policy makers? Yes.
I think it has an identity crisis. And I think depending on what you read, you'll get a very different definition. If you look at the AHRQ definition, it's going to be a lot different than those definitions that have been adapted by selected researchers or practice guidelines or whatever. So yes, I think that's a very malleable concept depending on who's looking at it. I think a majority are probably looking at only two features, and those two features are cost of care and outcomes. And I think that's too limited to look at. We have to look at a number of other elements too, including, are they appropriately matched in the protocol of best care for that individual? Is the patient experience appropriate? What about long-term care? Does that person continue to seek care because they didn't get what they needed at the previous value-based system? It was low cost, their outcomes moved a little bit, so obviously they're good, except when they go out and seek care with a different provider. So I think all of those elements need to be baked in, and I don't think we're there yet. I think it's pretty early in the process. By the way, for those of us who've been around for 20 plus years in this, they talked about value-based care way back when managed care was supposed to take over the country. It just never happened. So I'm not sure we're going to see any major tsunami-like changes with this. Chris, I'm going to have to wrap it up.
That's perfect. Do you have any maybe optimistic takeaways to go into the weekend?
Yeah, I hope you all aren't seeing this as negative. I'm just honest. And, I think a lot, when I left PT school, I mean, truly, I had these rose-colored glasses. I thought I was going to fix everybody. I thought within my hands was the power to fix everyone. And I really didn't understand the confluence of all features that influence health-related outcomes. And now I have a better understanding. I'm part of a system that contributes, but by myself, I'm only a small part. But understanding that is the first step. And then being a person that can help advocate for the best care for the patient. One of the best things I've learned the last few years is that if you understand the social support networks in your community that you can help your patients with by giving them access to certain community or resources or something that is going to negatively influence their outcome, you're going to see some major changes with that particular patient. I never thought of that early in my career. I thought it was going to be me in my cubicle with the patient. And so it's a lot of a bigger picture, but we can still make a lot of change and influence a patient's life. And the other piece too, other than just outcomes, think about experience. Experience is huge. They're called PRIMs, patient-reported experience measures. And it's really about how did this influence the patient? And sometimes those don't come out in PROs, but sometimes it's the little thing that makes the difference in that patient's recovery process.
Awesome. Well, thank you so much for coming on a Friday, middle of the day. I really appreciate it. Yeah, enjoy the rest of your Friday and the weekend, but this was great. Thanks again.
Yeah, thanks guys. Nice meeting everybody. Cheers.
Bye, everybody.